We're super lucky today to be joined by Tim and Dr. Mallick, CEO and CMO, respectively, of Hopscotch Primary Care. Rural health has been in the news a lot lately, but the Hopscotch Primary Care folks have been working on it for a lot longer than the recent conversations on the Rural Health Transformation Program. So we're excited to get their view, hear more about the business, and also what's going on in the rural healthcare world at the moment. First question for you two, I think, is on the headwinds or unique challenges that rural healthcare and primary care have. So when I think about it, I think, it's generally thought of as a hard business to be in. There's a worse payer mix, the labor market's a little bit worse. And so I'm curious to hear from you, like, what are those things that make rural primary care so challenging or difficult?
Yeah, sure thing. First, really happy to be here today. Been a long time member of the community, and serendipitous timing last night. A friend and colleague reached out who I talked to last year, and she wanted advice on a job search. One of the things I told her was, you got to subscribe to HTN, see what's going on, see what's really happening. And she emailed me last night and said she actually got a job through someone she met through the community, and she was thrilled. It was a really high impact startup that was like it fits really well for her passion. So shout out to Maeve, really congratulations as well. And you're right, we have been working on building out a model that is well suited for rural for a number of years. And now the policy world is turning its attention to the problem. And problems in rural are pretty well documented, but really under addressed from a sort of and then that rolls up to a policy level. We think of it in a few categories. Access problems writ large, and you hear about hospitals shutting down, hospitals, access to hospital services, inpatient emergency, and the like. Primary care is a really important adjunct to that. Primary care, sure, if you look at the relevant HPSA measures, sort of by any measure, almost every rural area has a serious structural shortage of primary care. There's a number of structural problems, whether it's technology, drive time, an aging workforce that is also driving the access challenges in primary care. And then a very high disease burden. So all of the chronic diseases are significantly higher burden in rural. In the Southeast, we have a number of other health burdens that our patients are dealing with. From our perspective, though, this is why we have built Hopscotch the way we built it. It's a high touch, high tech enablement model, a model that is directly solving the primary care access challenge. We are bringing providers to rural and small town communities in our launch market in Western North Carolina. We're doing it in a way that excites our teams and helps us recruit and manage our clinical hubs. And this makes a huge difference on the lives of our patients. And it's a great time to be building right now. Technology has changed dramatically, where the cost structure of bringing services, whether it's virtual specialty care or extending the capabilities of our teams, is dramatically easier than it was 5 years ago. And now there's this massive policy investment in the form of the Rural Health Transformation Fund, $50 billion. That's about 50x what the Innovation Center was on a per capita basis. So a truly massive investment in transformational care models, technology projects, workforce development, and directly supporting access in the communities that we serve.
And before we kind of zoom into your business and learn more about Hopscotch Primary Care, I was wondering if you could kind of talk to us a little bit about the Rural Health Transformation Program, and just sort of philosophically, given your vantage point as, working really deeply in this space, like if you were talking to a state, which I'm sure you are, about how they should use this money for transformative purposes, not just backfilling what they're going to lose from Medicaid, how would you think about how should they think about that investment?
Yeah, I think it's really important to take big swings here and to try to directly improve access, not attempt to paper over a system that isn't working, to not pour money into business as usual, essentially. And so to me, it starts with setting aggressive goals around improving access and improving actual health outcomes and mortality outcomes. It also starts with real thought about how you actually do that. And for what we do, that's directly providing access to primary care, makes a big impact on hospital utilization, on patient experience, on patient lives, and extends lives. And so we've seen, on a practical level, a number of the states we've been talking to are setting goals and applying for funding around directly increasing the number of PCPs per 10,000 population in rural counties. We've seen significant investments in topping up and extending existing workforce programs. And so these are, National Health Service Corps or there's a program in North Carolina called the High Need Service Area Bonus Program for mid-career physicians. These are really significant, and they allow us to directly pass through funding and support our teams in tapping into funding that can help increase their compensation by very significantly versus what they could get in urban areas. And then, the challenge isn't that people don't want to live in rural areas. A lot of physicians do. They just don't have access to the type of practice that they want to work in. That's something that we're able to do as well. And then for the non-hopscotch, you didn't ask about hopscotch in that question, but there's a whole bunch of ideas and initiatives floating around in extending hospital care and bringing virtual specialty services to rural and building out better support for maternity care and other shortage services that I think you can. The key to me is just try to really move the needle on a couple of really important things rather than try to boil the ocean.
I'll just add to what's so fascinating about this $50 billion transformation fund is the money has to be spent very quickly. It's a massive chunk of money that has to be spent very quickly, which means from a state perspective, you're looking at warp speed implementation. And one of the things that states really have to be able to measure up on is measurable impact that is sustainable beyond the 5-year funding cliff. And that's where, to Tim's point, investing in business as usual looks great for 5 years, but when you get to 5 years and a day, what happens? And so I think there's truly, in the spirit of transformation, this opportunity to invest in ways that are supercharging investments that can actually self-sustain beyond those 5 years, like investments in primary care.
Tim, I wanted to pick up on the comment you made about recruiting docs into rural areas. And I'd be curious, kind of, as you think about Hopscotch's model and entering a market like Asheville, could you walk me through, are you guys creating a Hopscotch tin in the market? And are you bringing docs into that tin, employing those docs in the primary care clinics? And then how do you think about that recruiting conversation? It strikes me that you could go the route of recruiting docs who have been in Asheville for a long time with new care model, new support resources. You could go out of Asheville, bring in docs who are, out of school, coming in, building out their panel. You can go to the advanced care model startups. How do you think about what that doc looks like and what that pitch is like to them when it's and to your point on it, it's not that hard to recruit to rural areas. It wouldn't take me much convincing to move to Asheville and go live in Asheville, but is Asheville representative of how does that conversation work across rural markets?
Yeah, great question. And I'll take the first part of that and working backwards a little bit. So I had a similar response to you when I was contemplating, is Asheville really rural? The communities we serve are not just Asheville, but are an hour and a half drive in every direction from Asheville. So we are really in mountainous Appalachia and a number of small and mid-sized towns surrounding the region. And so we have a lot of reps, even in our first launch community, where we have really gotten to understand what we need to serve these clinics and these areas so that they can be successful, both from a talent and from a care model perspective. There are a lot of communities that look like Asheville that are sort of medium-sized towns surrounded by a lot of small towns all over the Southeast and the Northeast and the Southwest. So this is a pretty common dynamic as we've looked at where we go next. And the question on how do we begin working with a care team? We have found this was a light bulb for me that makes a lot of sense. You think about the decline of independence across the country, a very well understood story at this point. That's a combination of IT and contracting and the difficulties of running relatively complicated small businesses at this point. That has hit rural especially hard. where physicians who have been leaders in their community and running solo or two-member practices for 30 years don't have anyone to hand their practice off to. They can't find a succession plan. And so there's a lot of patients that are sort of on the verge of losing their family medicine doc who they've known forever, and that family medicine doc is already drowning. And so our opportunity and what we can provide to those physicians is a natural transition plan into a care model that is very appropriate for their patients and that is very high touch and that makes a huge difference in their lives, as well as just the basics of continuing to provide access, right? Flip side is we can provide a place where physicians will want to work and not have to have the full responsibility for everything running a family medicine practice on their own. And Dr. Mallick has done a lot of thinking about how that evolves as we begin to as we grow and as we want to recruit more and more from both from the region and then from other parts of the country writ large.
Yeah, agree with all of that. A couple things I'd add, just Kevin, to your question of like, where do folks come from? Are they native to Asheville? Are they relocating? We do a mix. We've done a mix. I'd say that the core components that we look for are clinical excellence, care model excellence, like somebody that can understand how to operate in a full risk provider environment, and then people leadership excellence. What draws folks to us, I think where our value proposition to physicians and clinicians is the strongest, is a couple things. One, it's way more fun. Just literally like the day-to-day of working in a clinic where you are fully capitated, because you're not on the fee-for-service treadmill, right? Like our docs are not seeing 30 patients a day with 2,000 patient panels. So people have the time to actually get to know their patients. Like my favorite thing that our docs will say to me is, "Oh, this is how I've always wanted to practice medicine." And the business model, right? The capitation economics that underlie that makes that possible. The other thing is the tooling. It's, and Tim alluded to this, like this is not the independent primary care practice that I grew up watching in the 80s and 90s, right? Where like you work 80 hours a week, you're your own contractor, you run your own payroll, you pay all the bills, right? Like we handle all of the back office stuff, but alongside that, again, because of the underlying capitation model, we're able to staff these clinics in a way that's really effective. And so it's both the staffing model and then the technology that underlies that. So I'm a huge believer, having been a primary care doctor, like I saw patients in our Spruce Pine Clinic 2 days ago, like the ability to have technology and tools that wick away the administrative garbage, frankly, that is burning out doctors at unprecedented rates is something that we take really seriously. So that like that's how you actually make it both. There's an appeal to living in small towns and, like better cost of living, better work-life balance, but coupled with a practice environment that actually is fun and sustainable.
Yeah.
Before we get into the care model, I have another question on the human capital side of things. So, Dr. Mallick, when we first spoke, you talked about these entry points to the different entry points. I was wondering if you could kind of share with the audience the different routes that a doctor might take to considering a move to something like Hopscotch.
Yeah, I've often described medical training or the medical profession of like, it's like being on the freeway. Freeway if you're on the West Coast, highway if you're on the East Coast, right? But like there are defined exit ramps. One of the most clearly defined exit ramps is when you come out of your postgraduate training or residency. So there's an off ramp there because like you got to get a job, right? You're either getting a job or you're going on to additional training, like you're staying on the highway to go into fellowship. That's another exit ramp. And then beyond those two exit ramps, it's pretty stochastic. So people will move for a spouse is changing jobs, a family illness, right? Like people move and obviously people change jobs, but the window of opportunity from a recruiting perspective is the widest open at those exit ramps. And so one of the things that we're really working hard to build is the pipeline and the partnerships to be able to, alongside our university partners or alongside folks that are actually training the next generation of clinicians to be a place where those people can actually then come and work for years to come.
One of the things I'd be curious to pick up on in this. So we had town hall folks on a couple weeks ago to talk about their new fund, and it's very AI centric forward. And they talked about Hopscotch as one of the kind of leading examples of what they think is going on in the AI space. And I'd be curious if you guys could share a little bit about how you think about that technology tooling, how AI is changing that. Obviously, we read the news and hear about, there's a group in South Carolina that's expanding their urgent care / primary care model because there's more coding opportunities for them. We hear a lot about ambient scribing and whatnot, but I'd be curious if there are, like, how you, from a framework perspective, think about implementing AI as an organization, and then if there are any tactical use cases that you could talk to where you've seen particularly strong impact of it.
Yeah, for sure. I'll start, and then Dr. Malik can speak to some of our favorite clinical use cases. So, as I mentioned, we find it tremendously rewarding to be building these types of services and the supports for our clinical hubs right now, as opposed to several years ago, because the technology is, having fought the EMR battles for like two decades at this point, where everyone was fighting every step of the way, it was creating friction, and like it's flipped on its head. We still have to go through really careful governance and implementation processes, but like we're aiming for interventions that delight our care teams and our patients, and we're having a pretty good track record on that at this point. And ambient scribes really are a game changer. Just the sheer amount of it's enough of it shows up in our patient feedback, and patients notice that their doctor is talking to them, not talking to the keyboard. We, by virtue of being in a capitated business, we have the opportunity to leverage automation, technology, including AI, sort of across the full stack. So wherever we have significant administrative work going on, routine work, yes, with the care teams, but also with back office staff, all chart prep, all sort of the entire flow before and after a patient visit, or even before and after we get a patient engaged with us, we have the ability to, and have built a team that's capable and ready to deploy technology to dramatically simplify and leverage every member of the team. I will tee up Dr. Malik to talk about this is not AI, but like one of my favorite solutions is this, like, it's always been a desire to have rapid virtual specialty consults available. And we finally have solved it, where like we can actually get consults from 20 specialists to expand the scope of what a primary care doc can do in a visit within just a couple of minutes. And it's awesome. Really high support from the care teams, and you can see like how it can save patients months of wait times in many cases.
Yeah, I'm happy to jump in. Maybe, Kevin, to the first part of your question of like framework for how to think about it. I think about it as AI supercharges the care model. So there is no substitute for human connection. Like call me crazy and old fashioned about this, but like even in the era of AI, like we're not replacing the humans anytime soon. We are giving them additional teammates that can supercharge the best of clinical care alongside the best of human connection. And I think of like 3 specific domains where AI in the care model is really valuable. The first I sort of talked about is just like cut out the administrative garbage that like takes up time that nobody wants to do, right? Like AI ambient scribes are, I think, the perfect example of that. We've seen in our own data over 80%, I think it's about 85% of our PCPs use an ambient scribe over 80% of the time. It decreases pajama time. It decreases the amount of time they have to spend in the charts, right? It's like a rare case of a win-win-win. The second big bucket is around making care more effective, right? So we can now use AI to level up and exceed the standard of care around chronic disease management and other things. And then the third is where Tim left off around AI being able to supercharge access. So, like 20% of America lives in rural parts of the country. There are some people that'll tell you, oh, well, the future of rural healthcare is like everybody gets a chat bot and the hospitals will take care of all the procedures. And like, you stitch those 2 things together and like, great, you've now solved the access problem. But like 2 days ago, I had to drain an abscess. Like, who does that in the world of AI chatbots and hospitals, right? Like, there has to be the primary care layer that's so important there. But what AI allows us to do is, for example, care managers become that much more effective, right? They can touch that many more people. Remote patient monitoring becomes that much more effective. And in the example Tim gave, we partner with a platform, not AI specific, but in the broader theme of technology and tooling, where Our PCPs, our docs, NPs, PAs can pull out their phone, type in what's colloquially known in medicine as a curbside consult, and get a response from a board certified specialist in under a minute. And that saves the patient from having to drive, an hour in any given direction, very often saves them a trip to the hospital. So takes cost out of the system, delights patients, improves access.
That's a
That's
perfect
awesome.
lead in to my question, I guess, about your care model specifically. So if I'm thinking about a Hopscotch primary care clinic, what does that staffing look like? How is it, how are you sort of geographically spread out in the area? How close is like one clinic to another? Yeah, how do you staff it?
Yeah, our existing footprint is generally in the region, Western North Carolina region, 30 to 60 minutes, one removed from another. So we have solid density in the markets in which we operate. And, I've been spending a lot of time around the rest of North Carolina. We have connectivity with and really good visibility in the region. And so people I talk to in Raleigh almost inevitably have a parent or relative who's one of our patients. And so it's been really important to us to go deep and to be, a good partner to the existing healthcare infrastructure and to be additive to the access there. As Dr. Malik mentioned, we spend a lot of time making sure that we are staffing our teams effectively and that we are bringing talented leaders into those teams and then supporting them well. We have generally call them 3 to 4 provider clinic hub locations. And so these can support Medicare panels of 2,000 plus once they're fully at steady state. But it takes time to grow. One of the unique features of these markets that's sort of obvious when you think about it is like there is such a care desert nature to these areas that there's a lot of demand. You open up, people will come to grand openings, people will come take tours, have partnerships with the YMCA. We do a variety of community events. So it's a model where it's unusually easy to get people in the door, and then you demonstrate that you can provide a good quality service, and they're very engaged and loyal once they get to know our teams. Many of them have relationships with our care teams that predated our clinics, but that shows up, and we can really establish long-term relationships and get to know our patients very well, manage them better and better over time. Dr. Malik, is there anything you want to call out about staffing or anything that's different from your prior experience?
Yes. So what I'll say is just like within a given clinic, just maybe bring it to life. A medical director alongside an operational leader. It's important to us because we do track metrics really closely. So you've got somebody who wears that clinical leadership hat alongside somebody who wears the operational leadership hat. The 2 to 4 PCPs typically, and then we have not necessarily co-located in the clinic, but sort of quasi-centralized or hybrid across the region, transitions of care nurses, case management nurses, community health workers, and the like. And so that's what allows us to be able to do not just good primary care on the medical side, but to be able to get ahead of very often the social issues that can land people in the hospital or lead to utilization downstream. So very much a team-based model.
And given the rural nature of the business, how do you think about, like referring to hospital, like the curbside consult seems like a great application of technology. I would imagine though there's still times when someone needs to like go to the hospital. How do you think about, as a capitated provider, building out that referral network?
Yeah, I'm happy to start. It's very much partnership driven. And so like you're absolutely right. A cardiologist can tell you how to titrate a beta blocker, but like you can't cath someone over the phone, right? So there are things that you're always going to need to go to a hospital setting for. And we have around each of our clinics and sort of in the broader region, great relationships with our health system partners. And so we're continuing to build out or continuing to think about preferred networks of sorts, but we have some of that already in place. Tim, what would you add?
No, I mean, I think that's right. That you obviously you have limited options in rural parts of the country, so you work with what you've got. But I think establishing relationships so that there's continuous care management and follow up after any inpatient or acute utilization is it's a really important part of what we do.
Now that we've got 2 minutes left, I want to tee up one last really big meaty topic, which is value-based payments and how all of this gets compensated. Conceptually, I've got this mental model of this country doesn't pay independent primary care enough across the board. Rural health, that problem is exacerbated. So the model is generally underwater. That's part of what causes the financial problems. That's where it makes sense that global cap contracts come into play to help with that economic structure. I'm sure you guys have seen public markets, private companies, the issues with V28 global cap models. They kind of retreat from that, and now this like more thoughtful entry into risk. I'd be curious if you guys could share how you're thinking about supporting primary care payment models, what percent of the business is global cap, how you think about kind of what ideal unit economics look like from your perspective supporting primary care.
Yeah, no, I think that's exactly right. And so the way we think about it is a couple things I'd point out. Like one, we're an entirely post V28 business. We really have scaled up only over the last couple of years. And neither Dr. Malik nor I joined this business because we were interested in being like the best coding operation, right? Like it's important to fully understand our patients. Our patients have very serious problems, and it's essential to have a risk adjustment system that rewards capitated providers for taking care of sick patients. And I think that we see that the V28 world works just fine for that, and the economics work very well for rural regions because you have lower costs of inputs, you have lower cost of real estate, and a variety of other contributors that are tougher to deal with in urban, including what we talked about earlier of the demand side dynamics of patients are loyal once you prove that you can take good care of them. Broadening the lens a little bit, I think that we're in sort of a trough of a cycle right now where there's been a number of strategic challenges at the highest levels of the industry. But as we look over a period of decades, going back even to the 90s and before, we think the best primary care businesses have generally been built on a capitated infrastructure. It is what really aligns incentives and provides resources to overcome what you described accurately of the historic underpayment to primary care. But we've seen consistently in, whether California, Pennsylvania, Wisconsin, Tennessee, the best primary care and group practice models have been built on this type of infrastructure. And we see ourselves as bringing that best in industry standard to rural communities starting in Western North Carolina.
Kevin, I'll just interject quickly. I think we have them for 15 more minutes, so we can.
Oh, we do?
Yes.
I thought we were done at the bottom of the hour. Perfect.
Which is great because there's, I think, a lot of things we can talk about on this question. I'm taking that broader lens. Can you kind of talk a little bit about your payer mix and how you sort of is it mostly on the MA side? Do you do Medicaid, and are you taking risk on Medicaid patients? Can you give us kind of a flavor for that?
Yeah, our clinical model is senior focused, and so the core of our work right now is in Medicare and Medicare Advantage patients, and so we do take risk across our entire MA book. We have above 50% penetration of Medicare Advantage in Western North Carolina, and we are also in the REACH program. So between those two, we have very full saturation of our Medicare panel for the type of contracts we need. We do also care for some Medicaid patients and some under 65 commercial patients in areas where we have either made a practice acquisition, transition, and where we have maintained continuity of care for those patients.
I'd be curious what that looks like, having worked on some of these models before and thinking about the grand opening events in the community, whatnot, and how that shows up in the community and feels for like if somebody comes in and says, "Hey, I want care from you guys." How do you navigate that dynamic when it's somebody under 65, whatnot? Like what are your docs doing? Are they still seeing patients? How does that work in local communities?
Sure. Yeah, I think this is a little bit of a now versus what could be in the future question as well. Like we
Yeah.
have we were really focused intently on proving that our care model works for the populations for which it was designed, which is the Medicare and primarily the over 65 Medicare and duals population. That's been a tremendous amount of work, and we're really seeing the results of that right now in terms of performance, extremely high performance on quality ratings, extremely high patient satisfaction, extremely strong improvement on MLR. We do see, as I mentioned, a number of patients that are not in our sort of risk comparing contracts, and so and we do our darned best for those patients as well. In general, like community and other family medicine practices are happy to have support and happy to have additional capacity. And so I see us as, just like we're not trying to take on all hospital services ourselves. What we're working on right now is a major need care for seniors with a variety of chronic conditions. Over time, I do hope to roll in additional service lines that we can really focus on growing. And that's an ongoing conversation with the state and with our payer partners.
I'd be curious to hear a little bit. I feel like when we talk to folks who are taking risk, it's like in a normal risk contract, or not a normal risk contract, but in like the typical risk contract, a lot of the game is like, how do we avoid admissions and unneeded or unnecessary ER utilization? I'm curious if there's any kind of discrepancies or oddities specific to the rural population that make that different or more challenging.
Dr. Malik, do you want to take this one first?
Yeah, I'm happy to. It's largely pretty similar. I mean, if you think about, to Tim's point, so many of the communities that we serve, prior to our arrival, the primary point of access into care was a hospital. And so we see tremendous impact of our care model just by catching people sort of upstream and in a different site of care. And so spot on that on the utilization side, like the familiar drivers that you pointed out of keeping folks out of the emergency department and keeping them out of the hospital is really important. I think so it's a similar set of patterns as what you might see, let's say, in a more urban area, but it's amplified in a rural area because there are limited access points into care. I'd say beyond that, the other thing we focus a lot about is expanding the full scope of primary care so we can be the place where our patients get the most comprehensive care. So I gave you that abscess example, right? If you were I trained in Boston. In Boston, you would send that to a general surgeon, but we don't need to. We have the ability to do that within our four walls. And so it's both a shift on inpatient utilization, but also really maximizing the scope of comprehensive services available in primary care. And we see the same cost pressure that, I think everybody, like Mercer will tell you this, any big employer will tell you this, right? Like Part B drugs, right? Like specialty pharmacy is an area we have to look into. And that, again, it's not so much that it's different in a rural area. It's just, I think the way you solve for it looks different for us than the way you might solve it in a more urban area.
Yeah. Kevin, it looked like you had a question. Or maybe he's frozen.
Looks frozen.
It looks like he's frozen. So one of the other questions that I had is, it feels like in the Rural Health Transformation Program application, there was a lot of talk about advanced scope of practice or like a changing scope of practice. I'm curious what this looks like in North Carolina, and just sort of generally, what's your philosophy on, nurse practitioners, physician assistants, pharmacists, and APPs like that?
Dr. Malik, you start. I've got some thoughts as well.
Yeah, I mean, like I say this as a physician, and this will probably be a controversial thing to say. Maybe it won't. Like, there aren't enough doctors. So like if we continue to live in a world where we say, well, doctors are the only people that can provide this care, like, first of all, too expensive and not enough of us, right? So we're just headed towards, like, there's a very obvious supply and demand mismatch problem there, that when left unchecked is only going to cause like continuing upward cost pressure and access problems that we already find ourselves in. And so when you zoom out, I don't think there is any better option. And I say this having been a policymaker, like I don't think there is a better option than to say we need to think thoughtfully about how we expand scope of practice and making sure that people can operate at the top of scope and top of license. And so our model, certainly we have wonderful nurse practitioners, physician assistants on our teams. In North Carolina, the certification bodies require a supervising physician, and this varies state by state, as you no doubt know. But hey, welcome back, Kevin. We were just talking about scope of practice for advanced practice practitioners. In North Carolina, there's requirements at the certification bodies that are at the state level around supervising physician and frequency of case reviews and that sort of thing that we have sort of baked into our model, but also allows us kind of flexibility as we enter different markets and different states. But like globally, I don't see a way outside of the access shortages that we find ourselves in beyond being able to broaden scope of practice with appropriate oversight and supervision to make sure people get the access they need.
Yeah, I would agree to all of that. I think CMS has been very intentionally, really this is like a multi-decade project, right? With CMS wanting states to figure out a way to expand scope consistently for non-physician practitioners. And we certainly do prefer the expanded scope rules while respecting that there's a whole bunch of state equities and considerations that come up. But the CMS process has really ignited a lot of vociferous conversations in the states that we've seen. I think you've seen that in the handful of policy areas that CMS identified as well. They're taking on certificate of need. They're looking at promoting healthy behaviors and exercise programs. But I think that is having its intended effect. There's a lot of policy discussions happening in state legislatures and administrations right now on these exact topics. Oh, the one other thing I would say is we are huge proponents, and this is a real pain point bordering 4 states, of we need to make it dramatically easier to get licensed in a state that you are adjacent to. And North Carolina has seen policy progress on this last summer, that they're joining one of the big interstate compacts for physicians and nurse practitioners. But like, it's just way too hard to recruit someone from Tennessee to get them to drive 30 minutes over the border in North Carolina, get a license. It takes like 6 months, and this isn't like a North Carolina only issue.
It took me 6 months to get a North Carolina license. I've been licensed in 5 other states, and it still took 6 months. And so to Tim's point, right, like like we're staring down the barrel of an access problem, but for good reason. I'm not saying we need to blow up licensing, but the idea if somebody has been licensed, credentialed, and has a relatively impeccable record, it should be much faster than it is in practicality for that person to be able to ramp up in a different state.
Can I ask what actually takes the 6 months in a process like that? Like, is it just waiting on an approval? Like, where does that time go?
Yeah, again, from like painful personal experience. So, first of all, you submit every document ever about you. So like from, age 18 to, you don't need to guess how old I am, but it's been some time. And then you wait. And maybe you get an email or a phone call that says, Dr. Malik, we see that you didn't submit this thing from when you trained at blah, blah, blah place, or, so there's some amount of follow-up around just what I imagine is a documentation checklist, frankly, on their side. And then I think it's an incredibly human labor intensive process. So like talk about things that are ripe for automation possibility, right? Like it is literally a human that I imagine sits there and reviews scores and scores of pages now for individual applications. And so my sense is the bottleneck is just like entirely labor shortage or just the sheer volume of time it takes.
Yeah. The things you learn.
Yeah, that's right.
One of the topics I'm curious about in the industry these days is kind of the going back to the flow of VBC dollars and tying it to compensation model of physicians, like how the VBC performance actually impacts comp for providers in these practices and the types of conversations you're having with those providers around, here's what the model is, here's how you drive performance in the model, And, I know some practices share savings with their providers. And like, how do you guys think about that philosophically? What are the conversations you're having with docs and the practices about what these VBC models mean, what performance means, and how does that impact comp?
Yeah, I will start on this one because I want to, intentionally keep this relatively high level because some of this stuff is obviously sensitive for our team members.
For sure.
But I think it's really important to me that we pay our teams well and fairly, and that when we all succeed, then everyone should be compensated accordingly. And that will mean different things for different parts of the care team and different parts of the management team and what we call our clinic support center. So I think that getting alignment at appropriate levels around whether it's performing on a particular clinical initiative for care team members, and it could be a welcome coordinator, someone who's really driving patient with our care teams, might have appropriate incentives attached to something that's discrete within a quarter, versus I think it's also important to roll up for clinicians who are really impactful in affecting an overall market or community or hub's performance. They should also be compensated for success on those metrics as well. That might be much more longer term. They might be multi-year in nature, right? So it is something we spend a lot of time talking about, because I think it's really important. One, just to be fair and to be very aligned economically, but then two, to have a really attractive value proposition so that we are paying well in the market, and then ideally, with the help of those public subsidies, leveling up significantly what our team members could get if working with us versus working with someone in Chattanooga or Charlotte.
I want to draw a contrast here because I worked in a large health system that was part of an ACO model. And one of the biggest failures of the payment or funds flow in that model is think about the behavioral economics of it. You're relying on the provider at the point of care to be doing all the right things, right? Keeping people out of the hospital, doing all the quality screenings, like checking all of the boxes for what we all believe to be high value care. They reap none of the rewards of that, right? Because the ACO gets the money and maybe you get a check 6 months later, you're not sure what metrics it was tied to, right? But so the people doing the work are not the people that benefit financially from positive outcomes of that work. And so to Tim's point, one of the things that we take very seriously is an alignment of incentives around the outcomes that we know are going to be best for the care model, best for the business, and making sure that those incentives translate at all levels.
Now we are actually at time. And so I want to, first of all, thank you both. But for people who are curious and want to follow the Hopscotch story, how can people get in touch? Where can people find you on the internet?
Yeah, look us up, Hopscotch Primary Care. Dr. Malik has an increasingly prominent social media presence on LinkedIn. I'm trying to keep up. We've got a few other social channels, but LinkedIn and our website, Hopscotch Primary Care, which I think is actually, I believe we're at Hello Hopscotch. Am I right on the public facing version of that?
You are indeed. I'm also chuckling, Martin, because generally it's not hard to find people on the internet, but yes. LinkedIn or hellohopscotch.com would be lovely. Please do reach out. Would love follow-ups. As you can tell, we love talking about this. Like, always happy to chat. Tim and I are former government officials. Like, always happy to chat government programs. Happy to chat. Rural health. Happy to chat hopscotch. Appreciate you guys for the time.
Yeah, thank you guys.
Thanks so much.
Thank you so much.
Great to chat.
Bye.
See ya.
Bye.